Metformin, statins, and aspirin are three of the most commonly prescribed medications in the world for adults over $60 for diabetes, cholesterol, and heart protection, respectively. All three have decades of research behind their core benefits, and for most people who take them, those benefits are real and well established. But large, rigorous studies, including one of the biggest randomized trials ever conducted specifically in older adults, have also identified specific side effects that get far less airtime than the headline benefits, not because anyone is hiding them, but because a 10-minute appointment rarely has time to cover everything in the fine print. Today we're walking through 7 research-documented effects across these 3 medications, what large studies actually found, including exact numbers, and what's worth bringing up at your next appointment. We are not telling you to stop anything. We're giving you the fuller picture research has found so you can have a more complete conversation with your own doctor. Let's get into it. Metformin-associated vitamin B12 deficiency is well documented in the medical literature, particularly with long-term use. A 2025 study of community-dwelling adults 65 and older on metformin found that 29.4% had vitamin B12 deficiency, with the median duration of metformin use in that group being 9 years. Why this matters specifically for older adults? B12 deficiency can cause fatigue, nerve damage, and gait instability. And one published case report described an 84-year-old man on long-term metformin who developed frequent falls and eventually a subdural hematoma from a fall linked to undiagnosed B12 deficiency. Annual B12 monitoring is a standard recommendation for long-term metformin users, and it's a simple, inexpensive blood test worth confirming you're getting at your checkups. Clinical documentation lists reduced appetite and minor weight loss, generally less than 2 pounds, doctor, as an occasional metformin effect. For most people, this is neutral or even welcome, but in older adults already at risk of being underweight or losing muscle mass, an unnoticed, gradual reduction in eating is worth tracking rather than assuming it's simply getting older. Muscle-related symptoms are the most common reason people stop taking statins. Population-based research has found the reported incidence of statin-related muscle symptoms ranging from 10 to 23%, depending on how it's defined, and advancing age has specifically been associated with higher risk of these muscle effects. Here's where we need to be precise, because this is a genuinely debated area in cardiology research. Multiple randomized, placebo-controlled trials have found these muscle symptoms occur at nearly the same rate in people taking a placebo as in people taking the actual statin, suggesting some of what gets attributed to the medication may not always be caused by it. At the same time, real-world population studies consistently show meaningfully higher self-reported muscle complaints among statin users, especially older adults. Researchers are still working through why these two types of evidence disagree, and stopping a statin over muscle symptoms carries its own documented risk. One analysis found statin discontinuation due to these symptoms associated with nearly 3 times higher risk of a subsequent cardiovascular event. This is exactly the kind of finding that belongs in a conversation with your doctor, not a decision made alone. A more specific and less well-known finding comes from the MASTERS clinical trial, which studied resistance training in healthy older adults. Researchers found that statin use appeared to blunt the muscle growth response to structured strength training in this trial population, though it did not significantly affect strength gains overall, and combining statins with metformin in that same study actually appeared to offset some of this effect. This is a narrower, more technical finding than the broader muscle pain question above, but it's relevant if you're an older adult specifically working on building muscle through resistance training while on a statin. This is where the research gets most important for a specific group, healthy older adults taking daily low-dose aspirin purely for prevention without an existing heart condition. The Aspirin trial, one of the largest randomized clinical trials ever conducted specifically in this population, following over 19,000 adults 70 and older, found that daily aspirin increased the rate of major hemorrhage to 8.6 events per 1,000 person years, compared to 6.2 events per 1,000 person years on placebo. That's a 38% higher relative risk of major bleeding. A more specific analysis of that same trial found daily aspirin was associated with a statistically significant 38% increase in intracranial bleeding, bleeding inside the skull, from a combination of hemorrhagic stroke and other causes. The researchers specifically noted this finding suggests caution is warranted for older adults prone to head trauma from falls, since a fall that might otherwise cause a minor bump becomes a more serious concern if blood doesn't clot as readily. Perhaps the most surprising finding from Aspirin. In this specific population, healthy older adults without prior cardiovascular disease, daily aspirin did not significantly reduce cardiovascular events compared to placebo and did not extend disability-free survival. Extended long-term follow-up of the same trial confirmed no lasting cardiovascular benefit, while the increased bleeding risk persisted. This specific finding led directly to updated medical guidance, now advising against routine aspirin use for primary prevention in older adults who don't already have diagnosed cardiovascular disease. This is a critical distinction. This research is specifically about aspirin used preventively in healthy older adults. If you've already had a heart attack, stroke, or have diagnosed cardiovascular disease, aspirin's risk-benefit picture is different and well established. This finding is not a reason to stop aspirin prescribed for that reason without talking to your doctor first. If you're on metformin long-term, ask your doctor whether your B12 level has been checked in the past year. This is a simple standard test that's easy to miss if it's not specifically flagged. If you're on a statin and experiencing muscle discomfort, don't stop it on your own. Bring the specific symptoms to your doctor, since there are often alternative statins or dosing strategies that resolve the issue while keeping you protected. And if you're taking daily aspirin purely as a preventive measure, without a prior heart attack or stroke, this specific aspirin research is worth a direct conversation with your doctor about whether it's still the right call for you specifically. We want to be straightforward about something most videos in this space skip over. All three of these medications remain standard evidence-based treatments prescribed for good reason, and nothing here changes that for the specific conditions they're meant to treat. The statin muscle pain question in particular remains genuinely unresolved in the research community, with real, credible evidence on both sides of whether the medication itself, or something else, explains the symptoms many people report. The Aspirin findings are specifically about primary prevention, meaning aspirin given to healthy people to try to prevent a first cardiovascular event. They say nothing about aspirin's well-established value in people who've already had a heart attack or stroke, where the risk-benefit calculation is well-studied and different. The honest summary is this. These 7 effects are real, published findings from credible research, including one of the largest randomized trials ever done in this specific age group. They are reasons to have a more complete conversation with your doctor, not reasons to make a unilateral decision about medication you're currently taking. So here's the recap. Metformin's link to long-term B12 deficiency and appetite changes, statins' genuinely debated muscle symptom question, and a possible interaction with strength training, and aspirin's documented bleeding risks and lack of clear benefit specifically for healthy older adults without existing heart disease. None of this is a reason to stop anything today. It's a reason to walk into your next appointment with 3 specific, informed questions instead of none. And one more time, because it matters, please don't change any of these medications based on this video. Bring these specific findings to your doctor and let them apply this research to your individual health picture. If this kind of research-backed breakdown is useful to you, consider subscribing. We go through published studies like this every week, always with sources, always without hype. And if you know someone taking one of these 3 medications who's never had this fuller picture explained to them, this might be the video worth sending them today.